Dr. Greenwood.
Thank you. Well, this has been a great day. Thank you for having me. And, I have to, I'd be remiss not to say, standing in front of the room or the back of the room, how many familiar faces in terms of faculty, residents are still here. This is an incredible family, and you don't get that everywhere. So this is really a joy to come back and see everyone and to present a little bit about what I love, which is something that's actually been touched on literally in almost, I think, every lecture, particularly in Dr. Stanovico's. It's all about the cardiac output. It is. So that's what we're going to talk about today, because another comment that came up in between the lectures was, this is such a mystery to me. And there's a reason for that. You guys are all set up for failure in the emergency department in diagnosing cardiogenic shock. But that's just a systems problem, but you can fix it. I don't have any disclosures. I do have some research funding, some NIH funding, some industry funding. It's not relevant. It's relevant to the topic, but no conflicts or nothing conflicting here. We'll start off with a simple presentation. This is someone you guys see every clinical shift. Patient comes in, he's 71. He has a history of congestive heart failure, hypertension, diabetes. Over the past 3-4 days, he's just been not feeling all that great. Maybe some chills at home, some vague abdominal pain, and some shortness of breath. Also had a productive cough with this at home. You get his initial vital signs, and these are what you find. He's afebrile, heart rate in the 60s, systolic blood pressure a little bit on the borderline side, around 95, satting 96%. You get that trusty triage VBG that shows a lactate of 3. So you go and see the patient, you do your initial assessment, and 9 times out of 10, or maybe 8 times out of 10, you're thinking, what's the diagnosis early on? Well, most of the time it's infection, right? So you do an initial resuscitation just because that blood pressure is a little bit low, give about a liter of crystalloid fluids. You go back and recheck the patient. Blood pressure is still about the same. Maybe the saturation pulse ox is low, but then you look at it, it's really just not picking up all that well. It doesn't have a great waveform on the screen. You get a repeat VBG because that's what SEP 1 requires you to do to recheck, and the lactate is 6. And you're like, oh man, this patient's really septic, right? I got to do more. Well, I think we have to take Dr. Wood's suggestion and ask, what else could this be? Or force ourselves to ask the question of, is this what I think it is? What else could it be? And here's the problem. This is partly why you're set up a little bit for failure in the emergency department. I think when we think about shock, we think about these big categories. Most of the time, we're seeing in the bottom left-hand corner distributive shock, right? So this creates this recency bias of, well, most of the patients that come in hypotensive or ill with an abnormal lactate are in distributive shock, right? They need fluids, vasopressors, and so that's always in the front of our brain. But the fact is that an increasing number of patients that we see in the ED on a regular basis fall into this category of cardiogenic shock. Initially, probably about 15-20 years ago, it was more of that 15%, but we're seeing that number rise in the literature as well as in practice. In fact, over the past 15 years, we've seen an increase in over 3 times the number of cardiogenic shock patients that we're seeing in the ED. And there's a number of reasons for that. We're getting better at treating chronic heart failure. We now have guideline-directed therapies that are keeping patients out of the hospital longer and keeping them alive longer. But unfortunately, these patients have, as I'm sure you know and feel, have a very high hospital recidivism rate, right? They come back to the ED often because maybe their medications aren't working so well, or they have some other problem that tips over their heart failure into cardiogenic shock. And fortunately, though, I think, at Penn, we've increased our CCU census and volume by 3 times to match that. So that's been really good. No, absolutely not. Our CCU still has about 10 to 12 beds, and that's it. So what does that mean? It means that goes on you. You guys are responsible for A, making the diagnosis, B, managing the patient, and C, figuring out what to do next and where this patient can go. Because here's the problem. We've seen growth and improvement in our outcomes of sepsis. We've seen septic shock survival, mortality, go from 40% to 25% in the past 20 years as we've created surviving sepsis campaign guidelines. It's done a really good job addressing a major problem in the community. But unfortunately, I can't say the same for cardiogenic shock. Our mortality rate has been pinned at 40% for the past 15 years, despite getting better at identifying STEMIs, putting in stents, despite mechanical circulatory support options for patients, despite inotropic therapies. We have not seen an improvement in mortality of cardiogenic shock. So the question is really why? Why are we not getting patients better, and why are they not surviving in the acute phase? And that's an important question to me, and something I've been thinking a lot about over the past 5 to 10 years, especially coming from the background of emergency medicine, right? And so maybe time is one of those elements that's not being captured. And so I'd like to kind of start out with this idea of, well, how do we identify these patients with shock? And I think in sepsis we can identify fever, hypotension, lactate, which is somewhat of a non-specific finding for perfusion, might be more of a metabolic or prognostic sign. But the Society for Cardiovascular Angiography and Interventions came up with this kind of framework of how to think about cardiogenic shock. And it's not so much just based on one specific thing, such as a hemodynamic number. It is comprised of 3 different categories. So in order to diagnose this, you need a physical exam criteria, a hemodynamic criteria, and a biochemical criteria. So we're thinking, okay, can we identify this patient based on how they look? Can we identify them based on their numbers? And then do we have some evidence of end organ malperfusion that can point us in that direction? So within that framework, I think it makes a lot of sense. The question is, well, how well do some of these individual things that we look for perform in the ability to diagnose cardiogenic shock? So this was a paper published in 2021 in Intensive Care Medicine, where they looked at physical exam findings in patients with different cardiac outputs. And it was a 400-patient study that ranged anywhere from a cardiac index of 4 to less than 2. And I can tell you guys, if you remember a number for cardiac index, the map of 65 for cardiac index is about 2.2 liters per minute, and that's normalized over body surface area. But 2.2, all right, is a map of 65. Keep that number in your brain, okay? So when we honed down specifically on the patients with low cardiac output, there were 3 physical exam findings that had the best positive predictive value for cardiogenic shock or for low cardiac output. And those were capillary refill time, new onset or out of control atrial fibrillation with RVR, and altered mental status. Those were the 3 best physical exam findings for cardiogenic shock. But you see those numbers down there on the bottom. Those are the positive predictive values. What do you think about those? Are those pretty good when we think about diagnostic tests? No, they're not great at all, less than 50%. So there's not one physical exam finding you can hang your hat on to make this diagnosis, which is what makes it so tough, right? We have to take into account a number of different things and kind of put the pieces of the puzzle together to identify whether or not our patient is in trouble. Right? I think the best one here is capillary refill time. I actually use it all the time in my clinical practice. It's a really good flow-sensitive finding. So is the blood flow to my patient's peripheries good or adequate? If it's less than 3, great. Seems like we're perfusing pretty good. But if it's greater than 3 or 4, that patient might be in trouble. Obviously, lots of limitations with cap refill, such as skin color, peripheral perfusion or peripheral temperature, light conditions. I take that all into account, but I still rely heavily on capillary refill time. I remember Dr. Herr, who some of you may have known. He was the director of the HVI or CT-SICU here a while ago. Taught me whenever I go into a patient room, either if they're awake, shake their hand. If they're not, feel their feet. And it's kind of weird, but it gives you a lot of really important information. Okay, so something I still incorporate in my practice nearly on a daily basis. What about aside from physical exam, what about some hemodynamic criteria? How do they perform? So in that SCAI criteria, in order to achieve that C-level shock stage, classic for C, Most of the times it would require a heart rate greater than 100 or a systolic blood pressure less than 90. And we're not thinking about mean arterial pressure so much in cardiogenic shock. The systolic's really important because that tells us how well our left ventricle is squeezing. It's how well it's creating pressure. So that's why we use systolic blood pressure in cardiogenic shock. But again, you're seeing some really bad positive predictive values, right? And why might that be? Well, what's one of the main medications a lot of our heart failure patients are on chronically that might keep their heart rate down? Beta blockers, right? Some of them don't even have a heart rate of their own. They got a pacemaker in their chest that's set to 60, right? So that's not very reliable. So if you see that heart rate anywhere between 60 and 100, it could mean anything. So we have to put it in clinical context. Are they pacemaker dependent? Have they taken their beta blockers? Those are all really important clinical questions. And the biomarker side, so do they have new end organ dysfunction? I think the most sensitive one is probably a new acute kidney injury. The kidneys are really sensitive to low flow states. Oftentimes you'll see that first. I can tell you a lot of times you'll hear the cardiologist say, hey, this is just This is just cardiorenal syndrome. Cardiorenal syndrome is shock. It's malperfused kidneys, okay? Don't let that fool you. Don't let that name take you in an opposite direction of, oh, they're fine. No, they're underperfused their kidneys, or their kidneys are congested. We need to figure out a way to improve blood flow through those kidneys, all right? Lactate is a wastebasket of a biomarker. It can mean a lot of different things. Don't trust it. I'll tell you why in a second. But at the end of the day, I want to highlight this number here. This is your cardiac index of 2.2. Why is that important? Because we don't have a way to measure it regularly in the emergency department. When you look at your vital signs, what do you get? You get a temperature, a heart rate, a blood pressure, a respiratory rate, and a SAT, right? We never see a cardiac output. The cardiac output's responsible for the blood pressure. It's an indirect measurement of the cardiac output, but is not the cardiac output. And that number is important because it's augmentable and it's used for the diagnosis of cardiogenic shock. So we'll talk about how you can maybe measure that a little bit better in the ED. Now, this is a study that we're actually just about to publish. It's under review. Hopefully it'll be out in the next couple months, but I think it highlights some really important things that we feel clinically, and I'll just walk you through it real quick. What we did was we looked at a registry of cardiogenic shock patients who got admitted to Penn from a multiple number of EDs, so probably about 4 EDs, and within 24 hours were diagnosed with cardiogenic shock. We excluded a number of patients because we really want to focus on those chronic heart failure patients because those tend to come back to us a lot. In total, we got about 138 patients in the registry, and we did an observational study look at them. I can tell you that all of their age, demographics, comorbidities, and severity of illness were all the same. And we divided them into 2 groups. One into those who got inotrope support early and those who got late. And we defined that by 8 hours based on a mortality finding, which I'll show you in a second. So what did we find when we looked at the 2 groups of those who got early versus late inotropes? We found a couple of really interesting things. Those who got inotropic support early, oftentimes the most common physical exam finding that was recorded in this registry was that they had cool extremities. So someone did a peripheral perfusion exam in some way, shape, or form, but they didn't document something I think is really important. It's an objective measure of peripheral perfusion, which is capillary refill time. It's actually rarely measured. In fact, it was only reported in about 20% of patients with cardiogenic shock. So I think there's an area of opportunity there. What else was an interesting finding? Well, those who got put on inotropic support, actually the lactate was much higher, and that was in early inotropic support patients. Why is that? Because it's a biomarker we're comfortable with. It's one that we see often and we associate with shock, right? But I can tell you it's a late finding. And so if you're waiting until your patient develops a lactate to think about inotropic support to improve the cardiac output, you're setting your patient up for a much higher mortality risk than if you catch it a little bit earlier. And hypotension was actually associated with delayed inotropic support. And why might that be? Why might you think that hypotension might delay inotropic support? I can tell you, yeah, go ahead, actually. Love that. Yeah, absolutely. There's a risk of hypotension with inodilator therapy. And so oftentimes these patients will get put on pressors first. And you can imagine someone who's really clamped down in heart failure, cardiogenic shock, right? Norepinephrine might fix that blood pressure number, but it really doesn't address the problem. And that's something that we have to kind of rewire our brain to think about. What do we find? Some other interesting things. Number two, that those patients with delayed inotropic support often had delayed measurement of cardiac output, which makes sense, right? Like people maybe weren't thinking about it, or it took a while for them to get to ICU, or they got their echo, their pulmonary artery catheter, something like that. So, these comprehensive echoes that sometimes can take some time, we don't have ready available in the ED, but we do have ultrasounds. Oftentimes, delayed inotropic patients receive vasopressors first, which we just talked about, and they had much higher mortality. So that 8-hour cutoff is important. I'll show you why. But in patients who received inotropes later than 8 hours, their mortality rate was 32%. Compare that to only 17% in those who got it under 8 hours. Time frame is really important. I know in our ED, that's probably about the average length of stay. That might not be the same elsewhere, but it's important. And this is why. This is what we found. When we looked and we did some statistical work, we found that the odds ratio of death in patients who received inotropes late compared to early was much higher in those who received it late. And around that 8-hour point, it kind of had a cutoff. So you can imagine those who received it late, as we created these ratios, were dying more than those who received it early, okay? But here's another interesting thing. When we looked at the change in cardiac output and the change in mixed venous oxygen saturation, which is obtained from a central line or a PA catheter or whatever, all the patients responded as we would expect. There was no difference in response between the early and late people. So we were able to still augment the hemodynamics and the perfusion, but they still died more. So what does that tell us? It means that the wheels started falling off, develops like multi-organ dysfunction, and instead of treating one organ, the heart, which was the problem, we ended up having to fix other organs too. And that created a higher risk of death in these already sick patients. So when I teach my residents, what I like to talk about is this concept of a hemodynamic profile. And what is that? Historically, you might remember this of when you go to see a sick heart patient. Are they wet? Are they warm? Are they dry? Are they cold? I think that's kind of outdated. I like to think about this in terms of things that I can fix. What numbers can I change that might help improve the likelihood of this patient having a better outcome than what we've historically done, which has led us to a persistent 40% mortality, right? So we're kind of moving to this different concept of what a hemodynamic profile is. And this paper was published by Jacob Genser and his group, who's done a ton of publishing in cardiogenic shock, and particularly in registries and large scale observational studies. And they identified 3 different phenotypes, all right, that kind of fall into this idea of what's a hemodynamic profile. They're the patients who come in non-congested, which have a mortality rate somewhere around 20%. So these patients are kind of like just low output, but they're not fluid overloaded and that sort of thing. You have the cardiorenal patients, which have a mortality probably somewhere around 35%. And that's when you start seeing that earlier sign of acute kidney injury in low cardiac output patients. And then you have your cardiometabolic patients. These are the ones with the lactate that's abnormal, or the liver dysfunction, because they have multi-organ dysfunction now. And their mortality in over 2,000 patients was around 50%. So if we can tackle one specific type of patient, ideally, it's to identify that patient that maybe has a lactate that might get confused with a septic shock patient or something else. And so how do we identify them? And this is where I use a lot of ultrasound. And Dr. Earl, taught me, he kind of planted that seed. And, certainly since I work in a cardiac ICU, I use it a lot. But this is something that you can do. And so if you can identify two things with your ultrasound, you can nail that diagnosis of cardiogenic shock early. And when we looked at that highest risk patient population, the cardiometabolic group, What are the variables that we have? We have a mean arterial pressure, we have a heart rate, we do not have a CVP or a radial atrial pressure, and we do not have a cardiac index. So how do we get those important pieces of data to help us nail that diagnosis? Well, I'm going to show you. And I think we've used ultrasound in emergency medicine a lot, and we've used it as a terms of like a screening test or a screening tool, right? There's a number of different protocols out there. There's not one for cardiogenic shock. I'm not trying to create one. I'm just trying to show you how you can do it. But certainly if you're comfortable with using ultrasound, you can basically get these measurements in less than 2 minutes. So how do we do that? How do we measure cardiac output? This is a study that was published probably about 2007 looking at whether or not a cardiologist could accurately measure cardiac output. The data points, what you're seeing along those lines, just show that they're really close. And there's not a lot of variance in their measurements, but it ties really well with invasive cardiac output measurement, okay? But here are some limitations with this, right? A, we're not cardiologists. B, these were in stable outpatients who weren't in heart failure and cardiogenic shock. And then C, some of the measurements they introduced were like really complex and not something I think that's really relevant to a patient encounter that might be 5 to 10 minutes at most. We got to get these measurements quickly. So all of these things don't apply, but it does show that cardiac output can be accurately measured with an ultrasound. So let's find another study that might be a little bit more relevant. This was measuring cardiac output. This was done by Paolo Mercado and his group, where they took ICU patients and they said, okay, these patients all have SWANs. How does our ultrasound measurement as critical care doctors compare to the invasive hemodynamics, which are the gold standard? And these were general ICU patients, so a lot of them actually were septic shock. So these were high cardiac output patients. So again, can we measure accurately when the cardiac index is actually low? That's a really important question. This didn't answer that, but it showed that non-cardiologists could do those measurements. And I equate us to the same as intensivists, so we can do it. These were paralyzed, and they didn't measure some of the other really important variables, such as CVP, and didn't touch on RV function either. This is probably the best paper if you want to look it up. Probably worth a read. It's by Simone Frey, this was just published last year in the summertime. As I was putting together one of our projects, I was like, scoop me, but that's okay. So this was where she's created almost like a comprehensive, non-invasive hemodynamic profile. And this was also by critical care doctors, but these were patients with low cardiac output. These classified as that classic SCAI C shock in about 100 patients. They basically did their cardiac output measurement within 30 minutes of getting their right heart cath, and then they compared them. So this wasn't at the same time. This was about a 30-minute interval prior to getting that invasive measurement. So a little bit more relevant to what we might see in the ED. We're not putting SWANs in the ED, but if we get a measurement in time around the same time as invasive monitoring, is that helpful? And what they found was that, yeah, actually is. It correlated really well when they did their correlation and their regression analysis for cardiac index, as well as filling pressure, right? What's their preload? What's their CVP? That's an important number here, and I'll explain why just a minute. And again, always advocating for right ventricular function because that can be helpful. So you might be saying, well, wait a second. IVC ultrasound isn't all that helpful, right? That pendulum is swung back. It's kind of like, there's a lot of confounders, and it can be a flawed measurement. I'm not talking about IVC measurement to assess volume responsiveness. That's not what I'm talking about here. What the key point that I want to know is what's the pressure on the right side? What's the preload? What's the CVP measurement? Are they congested? Is there a lot of volume in the venous system? That's actually a very different question of, if I give fluid, will I improve my cardiac output? So that's not what we're talking about here. This was a study published probably about 10 years ago where they looked at how well IVC size and how dynamic it is with inspiratory variation. Can it estimate a high CVP? So again, think about cardiogenic shock, low cardiac output, high right-sided filling pressures, right? and it actually had a really good positive predictive value. It was somewhere around like 85 to 90%. If their IVC was flat, it was a low CVP, good negative predictive value as well. There's always some things to be cautious about. You have to be aware if the patient has really bad tricuspid disease, if they have a high intra-abdominal pressure or a high respiratory drive, that might give you a false change in your IVC variation, but it can be used and is valid as a measurement of right atrial pressure. And there's tables about this in your textbooks, and we've adopted one of these into our own pen echo kind of reference measurements. As we get a comprehensive echo, they'll also report what the estimated CVP is. And that's a helpful thing to guide us as we're thinking about therapeutics, which I'll explain shortly. So this is kind of the idea. This is the concept, right? Cardiogenic shock is different from septic shock in that septic patients are vasodilated, they're vasoplegic, they have a really low afterload, and you have to give them a pressor to create tone, right? Well, cardiogenic shock is exactly the opposite of that, all right? It's a high resistance system, so your afterload, your systemic vascular resistance is high, and the flow is low, right? So when the flow is decreased, cardiac output's decreased, that creates hypotension because there's no volume in the arterial system to create tone, which creates a blood pressure. So when I'm doing my non-invasive hemodynamic profiling, I'm trying to measure my cardiac output, my right atrial pressure, I'm using that to answer a very simple question. Okay, if I found out this patient's in cardiogenic shock and I need to start an inotrope, if my resistance is high, that difference between my MAP right atrial pressure over the flow of the circuit, the CVP or the cardiac index, if my resistance is high, that concern about hypotension with my inodilator therapy no longer exists because it's going to relax the tone and create more cardiac output. I don't have to worry so much about hypotension. If I do this kind of mental framework and the systemic vascular resistance is low, maybe they're a mixed shock or they're starting to develop multi-organ dysfunction, and I need to increase my cardiac index, I might think about a different drug. Instead of dobutamine or milrinone, which is an inodilator, I might think about epinephrine, which gives me not only the benefits of inotropic support, but also some alpha to create tone, okay? So I can reverse some of that low SVR state and improve my cardiac output as well. So this is how I'm guiding my inotropic decisions. It's based on my ultrasound, as well as some of the other things that I've just discovered through my physical exam and a few other things. So I use this as a safety check when making a decision about inotropic support. All right, so my last goal for you today is to teach you how you can do this in less than 2 minutes, okay? You can do this, it's not difficult. You actually already get all the views that you need to get in ultrasound. So let's just go through it real fast. This is our patient. This is the gentleman who you saw before, the 71-year-old who came in a little bit hypotensive with a lactate of 6. He had a mean arterial pressure that kind of was hanging around 68. His systolic was low, and he was already put on a norepinephrine to try to get that, to keep that blood pressure. They thought maybe it's a relative hypotension. Let's get his MAP up to over 70 and see if we can clear that lactate. Okay, you can see this is our parasternal long view. This is something we get on everybody, but we can get some really important measurements because you might see, well, they have a low EF, so it's cardiogenic shock. Low EF doesn't matter. How many patients do you walk by on the street that have an EF of 30% and they're well perfused, right? It's a screening test. It's not like an actual measurement of what the cardiac output is. So if you have a patient with a low EF and they're malperfused or have end organ injury, think about cardiogenic shock. All right, so let's go back to that parasternal long view. And what we need to do in order to measure cardiac output is identify and measure the aortic valve area, which is basically the diameter of your LVOT, and the flow that's going through the LVOT every time you get a contractual beat. Okay, now fortunately, all of our modern ultrasounds, I'm not tied to any specific ultrasound device, they can do these calculations for you. You don't have to write it down on a piece of paper and do it. It may be helpful to learn it, but when you're actually using it in clinical practice, your ultrasounds will actually do the calculations and the measurement for you. You just need to put in a couple important numbers because if you can remember, Stroke volume is how much volume of blood flow is per beat. Is equal to basically the measurements I'm going to show you how to get an ultrasound. We multiply that by the heart rate, and then all of a sudden we have our cardiac output and our cardiac index. Remember that 2.2 number, that's your map of 65. That's what you're trying to achieve in your patient with cardiogenic shock. So we've identified where our LVOT is. We're going to pause and we're going to measure the diameter of the LVOT just below the aortic valve. And when we put in that measurement, we're going to click LVOT diameter. It's going to measure in centimeters. Normal is somewhere around 2 centimeters. And it's going to calculate for you what the aortic valve area is, which is great. That's our first step. Then afterwards, we're going to slide down to our apical 4-chamber view. And this is going to be the added step that you have, which is doing a pulse wave Doppler through the LVOT. So this is our very familiar apical 4-chamber view. We've kind of flattened our ultrasound probe just a little bit to show us that LVOT. And when we press that pulse wave Doppler function, we're going to put these 2 little gates just in the LVOT below the aortic valve. All right, and when we do that, we're going to get these measurements here. Now, I want to take a pause. Don't worry about what this is. What do these waveforms down the bottom, if you had to think of the last time you looked at a clinical monitor, maybe in a really sick patient in the ICU or in the ED, what do those waveforms look like? What's that? An A line. Yeah. All it is flow through a tube, right? Same thing actually with pulse ox. All it's measuring is flow through the capillaries. So this is the same exact thing conceptually. It's just flow through a more proximal site, which is the LVOT. And if we can calculate this and measure it, here's what we can do. We can actually measure what the LVOT is. And this is done, you can do the automated. I don't like the automated. I kind of do like a kind of an averaged kind of way of doing this. But that's something for another talk. But once you get this measurement here, you multiply the LVOT by aortic valve area, and it gives you a cardiac index. All right, and you usually get like 3 to 5 measurements of these VTIs. Now this person's cardiac index was 1.9, so are we good or are we bad? Bad, right? Yeah, we definitely have some opportunity for improvement here. So we've measured our cardiac output. We've estimated our right atrial pressure. We can generally get a sense of if this patient is in a high resistance cardiogenic shock state or mixed shock state. We know this patient needs some sort of inotropic support. I'm going to just encourage people to, if you're going to learn another kind of thing that's kind of fun, the TAPC to measure RV dysfunction, this is more like the advanced next step thing, because you might think about, oh, well, maybe my RV is bad as my primary cause of cardiogenic shock. And there's some different therapeutics that you would initiate here, and it's a little more nuanced. If you guys can get the cardiac output part, that's the most important thing. But this is a very simple measurement too that I usually do in my hemodynamic profiling, which is I'll do a TAPC, and that tells me whether or not my right ventricle is struggling or not. And with that measurement in M mode, I can calculate if that vertical movement of the lateral annulus tricuspid valve is kind of low, it means their RV is struggling as well. We might need to do some different things. But let's get back to our patient. Remember, this is a patient who got a little bit of fluid resuscitation, is still hypotensive, and now we've identified he's hypotensive still with a lactate that's rising. Well, we did a quick LVOT VTI. And when we get the numbers into the system, we've identified that he has a low cardiac index, a high filling pressure. These numbers aren't on our clinical monitor, which is why you're set up for failure. And it's a high resistance or high resistance kind of tone in the circuit. This patient needs an inodilator. All right, that's going to improve the lactate. That's going to improve the peripheral perfusion. All the things that you're seeing that are abnormal will improve as you get this patient's cardiac output up and the resistance down. So I'm just going to end with this, that we're talking a lot about cardiogenic shock. But if you practice this in patients who are really sick, it'll also give you that, well, what else could this be? It'll answer that question for you. And it doesn't just have to be practiced in patients with heart failure. I use it in patients with sepsis. And it's more or less of a, it confirms the diagnosis for me rather than just and I get more reps at it. So, getting back to this patient, it's a different patient, comes in hypotensive or whatever. You do your cardiac output measurement, your VTI, and this time the number's a lot higher. The stroke volume's really high. We've measured a cardiac index of 4.7, right? This is a high output state. Maybe this patient's in shock. They have a low SVR, right? So if they're hypotensive, right, and you add on a vasopressor, your cardiac index might come down a little bit because you've increased tone of the circuit, but you fix the blood pressure and everybody's happy, and you go on, continue with your antibiotics and all those other things. So I utilize this also, not only in heart failure patients, but in patients who are hypotensive to kind of help me guide my hemodynamic interventions. And also gives me opportunities to teach the residents, the fellows, of how to put a mental framework in these patients that goes beyond just addressing the numbers on the screen that you get of hypotension with an abnormal lactate or end organ injury. You can really identify this is the intervention that's going to reverse this abnormality. It's going to address the primary problem that's driving this patient's malperfusion, and hopefully get that patient a little bit better a little bit sooner. So with that, please keep that in mind. Next time you walk into the room, recognize that you're being set up for failure. You're given the vital signs that give you an incomplete understanding of what's wrong with that patient's hemodynamics. So take a pause. Think about, what else could this be? If you have the opportunity to practice ultrasound and you have one in your emergency department, use it. Practice it. You might not get it right the first time, the second time, the third time. But the more reps you get, the better you'll get and the faster you'll get. And you'll be able, with two simple things to add in your normal ultrasounding, really answer a lot of important questions when that patient's hanging out waiting for that ICU bed that won't be ready yet for another 12 hours. So with that being said, this is my email, this is my Twitter. Please, if you guys have any questions at all, after the fact, you don't want to raise them here, shoot me an email. I'm always available. I'm happy to talk about this stuff. It's what I do for a living, and it's my only hobby, unfortunately. So I'm always happy to talk about it, but thank you very much.
Thanks so much, John. Let me turn to Eileen for one last check on the chat box or questions.
Yeah, Kristen in the chat wants to know, do you have an adjusted MAP goal for cardiogenic shock patients?
Nope. So the question is, do I have an adjusted, I guess we already have that one. Sorry, Dr. Bond, you kind of put the fear of God in me. So
brought back memories.
Some things never change. So no, I don't have adjusted MAP goal because that's really not what I'm targeting per se in patients with cardiogenic shock, right? I'm targeting a normalized cardiac output and then checking their perfusion with it. So listen, I get there's guidelines out there, but this is the fun part about medicine, is that we can go, part of being a physician is you get to go off the guidelines when you think it's the right thing to do for your patient, right? That's your expertise. And so I really use my perfusion exam to guide, what I want their hemodynamics to be, and a mean arterial pressure is just one number. So if my cardiac output good, my MAP is good, and my cap refill, my mental status, maybe even my lactate are good, I'm feeling pretty good. So I don't have a hard and fast number.
And then if you are attempting ultrasound on them and you can't get any good views at all, is there anything else you recommend to kind of gauge that cardiac index?
Yeah, so it's a tough one. What can you use instead of ultrasound to measure cardiac index? There's a lot of devices out there, FlowTrack and a few other things. Non-invasive hemodynamic NICOM is another one that have come around. They all have limitations. So, I guess any number could be better than no number. As you saw, that when we tried to find physical exam, hemodynamics, and biochemical markers of cardiac index, they don't perform all that well. So, I think that unfortunately we don't have a great answer for that. That's a huge gap in clinical care, and something that just hasn't been solved just yet.
And one last question from Toshi in the chat. Is there any role in a push dose of epi when you have undifferentiated shock, but you're considering cardiogenic shock more?
Nah, because I just figure out the answer first before I try stuff. It's a great question, and if you don't have the data point, then sure, you consider it. But I think it's really important to answer that. What am I trying to fix? before I start pushing in meds, just because you can sometimes make things worse. Yeah, so the question was, can you just use VTI? Do you need to actually do the full cardiac index measurement? There's pros and cons because, right, like if their aortic valve area is small and all of a sudden they have an AVA of like 1, and then your stroke volume is kind of, it's one number in the equation, right? We don't know as much about whether or not VTI or stroke volume in isolation is adequate for perfusion. So some people do that. I'm not saying it's wrong. I'm going to say that there's not enough data to support that practice or support not using that practice. I'll take the other side of the coin too. It's a great question. So the question was, what about patients with AFib? We showed that that was one of the signs for someone who could be in shock. And we know atrial fibrillation, the fact that you're not contracting in an organized way, can make your stroke volume highly variable. In general, if that's the case, what I'll try to do is take more measurements. So I might, instead of taking 3, I'll take 5 to 7, and I'll average them over the course of a longer period of time. It's kind of like any diagnostic test. Oftentimes we'll start in triplicate to try to make sure we're reducing the variation. The more you take, the more you'll reduce the variability in your actual number. So it gives you a better sense of what that measurement actually is. There's no way around it, unfortunately. But taking more samples will kind of help you get more close to the number you're trying to get. Yeah, exactly.